This is our ventricular chamber. When blood enters the chamber, there's going to be a distending force. We call this the transmural pressure, and we label it P. Directly fighting against this expansive force is what we call wall tension, and we'll label that T. This is the force that wants to constrict the chamber back to its original circumference. In addition, we have one more variable, which is R, for the radius. This does not include the ventricular wall thickness. The radius and the thickness of this myocardial wall are the two other components of the equation. So some really smart guy named Laplace put all this together into an equation, which is the wall tension, which is sigma, equals the transmural pressure times the radius divided by 2 times the wall thickness. So this equation tells us the factors that determine wall tension, which is sigma, and myocardial oxygen demand. In your mind, think about wall tension as the same thing as myocardial oxygen demand and ATP use. So let's work through a clinical example like hypertension to understand how this actually applies. So if someone is suffering from hypertension, they need to pump much harder due to an increase in afterload. Now what is the heart going to do in response? Well, just like when we go to the gym and lift weights to get bigger, the stressed myocardium is going to add sarcomeres in parallel. So this means that it's going to start adding bulk by increasing the thickness of the wall. So we're going to increase the denominator. We add sarcomeres towards the middle of the ventricular chamber. Now we call this concentric hypertrophy. We can see that here. Notice how we've added sarcomeres in parallel, and now we've added ventricular muscle to more easily distribute this stress. So the concentric hypertrophy has a problem though. Notice how we have decreased the radius. We've decreased the radius of the ventricular chamber, so that means now less blood can enter the chamber for future contraction. Despite this, we've dropped the wall tension because less blood means less blood pressure in addition to more surface area to distribute the transmural pressure. Now, if you look at the equation, remember, wall tension equals the pressure times the radius divided by 2 times the wall thickness. So we've increased the denominator by increasing the thickness of our myocardium, and we've also decreased the radius. And overall, we're going to increase the denominator, increase the numerator. This leads to a severe decrease in the wall tension. So this end result of a large drop in wall tension is going to also lead to a decrease in the myocardial oxygen demand. So we're going to revisit this concept of adding sarcomeres in parallel or series when we discuss diastolic and systolic dysfunction. So for now, let's move on to preload. Now preload is equivalent to the ventricular end diastolic volume. This is the volume of blood in the chamber right before systolic ejection. What determines how much blood is present in the ventricle at the end of diastole? Well, it's circulating blood volume and the tone of the veins transporting blood back to the heart. Now venous return is driven by the pressure difference between the veins in the right atrium. We define it by this equation. So venous return equals venous pressure minus right atrial pressure. So if I were to give someone a low dose of nitroglycerin, what's going to happen? Remember, a low dose of nitroglycerin is a venodilator. At high doses, it's going to also dilate arteries, but we're talking low dose, so only a venodilator. By giving this patient a low dose of nitroglycerin, we're going to decrease the venous tone. This decreases the driving pressure because we drop this variable here. There will be a less of a gradient for venous blood to return to the heart. This decrease in venous return leads to a decrease in the preload. This is the fundamental physiology behind treating a myocardial infarction with nitroglycerin. Less venous return means less stretching of the sarcomeres and less myosin-actin interactions, therefore less oxygen demand. So now we talk about afterload. Afterload is approximated by the mean arterial pressure, which is approximately 2/3 of the diastolic pressure plus 1/3 of the systolic blood pressure. A hypertensive patient's heart is always pumping against an elevated mean arterial pressure. This is a bad thing. Remember, we just discussed this concept on the slide about myocardial oxygen demand. We can go through it again to make sure that we get this down. So an increase in mean arterial pressure, or afterload, will increase the pressure on the left ventricle because it must create a sufficient amount of pressure to eject blood. This increase in pressure is going to lead to an increase in sigma, or wall tension. So think about it like stretching a rubber band with one hand. The stretch you create is the same as the transmural pressure, and the rubber band wanting to recoil back to its original shape is the wall tension. So a thicker rubber band would be able to handle the stretch more easily, right? A thicker rubber band can disperse the pressure along a larger surface area. So here's an image that we're talking about. This is why myocardial wall thickness increasing in response to chronic high pressure makes sense. We go from a normal thickness to this situation where we've increased the thickness of the wall and decreased the radius of the ventricular chamber. This is concentric hypertrophy. This ventricle has hypertrophied or increased myocyte muscle mass. Just look at how thick this wall is. This is beneficial temporarily because, according to Laplace's equation, we have to increase the wall thickness by adding sarcomeres in parallel in order to alleviate wall tension. The main goal is to decrease myocardial oxygen demand. It would be ideal to address the hypertension to prevent this from happening, right? So what are you going to give your patient? Well, the problem is that the afterload is very high. So we need to give something to decrease the arterial tone. We can give them hydralazine and drugs that inhibit angiotensin II's vasoconstrictive effects. We're talking about ACE inhibitors, or if they can't tolerate that, we can put them on angiotensin receptor blockers. Now, ACE inhibitors are particularly useful because they also prevent venoconstriction and also help drop the preload. So one last variable left, ejection fraction. Ejection fraction is super high yield because whenever you get an echocardiogram, you always look at the ejection fraction to give you an idea about ventricular contractile function in a single cardiac cycle. Now, if it's normal, it should be above or equal to 55%. Now, the amount the ventricle ejects is the stroke volume. This is calculated by the end diastolic volume minus the end systolic volume. We subtract the volume at the end of systole from the volume at the end of our diastolic filling period. So if we take this difference and divide how much we started with at the end of diastole, we get a ratio. This tells us that there could potentially be a problem with ejection. Because ejection fraction is a ratio, not an absolute number, it is normal in diastolic dysfunction and abnormal in systolic dysfunction. So let's say normally our end diastolic volume is 120 milliliters, and these are the exact actual numbers for normal. Our end systolic volume is 50 milliliters. So our numerator and stroke volume is 120 minus 50, or 70 milliliters. Now we divide that by 120, and we get our ejection fraction to be 58%. This is a normal ejection fraction. It's above 55%. Now, when we're talking about systolic dysfunction, the problem is poor contractility, so the volumes in the ventricular chamber are all going to be higher. Our end diastolic volume goes up to something like 200 milliliters because the heart cannot push out the same amount of blood per cardiac cycle. And our end systolic volume will also be increased from 50 to something like 150. So now we have 200 minus 150 divided by 200. This gives us a below normal ejection fraction of 42%. How is this different in diastolic dysfunction? Well, let's talk about it. In diastolic dysfunction, remember, contractility is great. The problem is in diastole. A poorly compliant and thick ventricle does not allow the same volume of blood to enter the chamber. This means all volumes are going to decrease together. So this makes our end diastolic volume lower. It's somewhere around 100 milliliters instead of 120. And the end systolic volume will be proportionally lower at around 40 milliliters because there's less blood to be pumped out overall, right? So if we do 100 minus 40 divided by 100, our ejection fraction is going to be even better than we think at 60%. This can be misleading because it appears that everything is normal, but the problem is that there's just not enough blood being pumped into the systemic circulation because all of the volumes are lower. So don't be surprised to get a question that requires you to plug and chug some numbers to understand what's actually going on with the patient's heart. Let's go on to an important figure that might show up on your Step 1 exam. Board examiners love this stuff. It gives them a chance to test physiological concepts using a diagram. It makes people nervous. We don't like diagrams, right? So Frank Starling was trying to figure out this cardiology stuff using dog hearts. He observed that when he increased venous return, aka preload, the result was that there's also an increase in stroke volume or cardiac output. So what did our boy Frank do? Of course, he made a curve and put his name on it. Here we go. The Starling curve plots ventricular end diastolic volume, which is basically the same thing as our preload, and stroke volume or cardiac output against each other. Now, why did Frank make this curve? Well, he wanted to visualize the interaction between ventricular distension and diastole down here and see how that affects how the blood is pumped out of the heart. He came to the conclusion that an increase in preload stretches cardiac muscle fibers just like a rubber band. The more you stretch them, the more they will kind of bounce back. So normal here is in the middle. This shows that the stroke volume can be influenced directly by how much these sarcomeres are stretched in the ventricle. This all occurs up to the point at which they have maximal contraction ability. Remember that this is only true up to a certain amount of stretch. You can actually outstretch the sarcomeres, causing decreased ability to contract back to normal. Now, what would cause a downward shift in the Starling curve in which we drop stroke volume for a given preload? Heart failure is definitely one. Be on the lookout for a similar diagram that tests your ability to apply the concepts behind the Starling curve. So what's occurring in heart failure that has pushed us down this diagram? In heart failure, we eventually get to the point where our sarcomeres cannot contract for a given end diastolic volume. So there's a very large preload, but the subsequent contraction is very weak. It does not eject the same ratio of blood out of the ventricle. So there's going to be a drop in stroke volume, and this pushes us down the curve. So how does digoxin help us get back up the curve, back in our favor, up and to the left? Well, this is how it works. Remember, digoxin competes here at the extracellular binding site of potassium on the sodium-potassium ATPase. By decreasing the ability of the pump to push potassium in and sodium out, we're going to obliterate the gradient for sodium to be pumped in while calcium is pumped out. Therefore, we get an increase in intracellular calcium. This leads to an increase in troponin C binding by calcium, and therefore we get more actin-myosin interactions, and this leads to an increase in inotropy. So the result is that we have increased calcium to bind troponin C and ultimately boost inotropy. This is why digoxin is called a positive inotropic agent. So it's going to increase our stroke volume and shift us back up the Starling curve. So here we go. So here's our arrow. Notice how for a given end diastolic volume, we have now shifted up the y-axis because now we have a better stroke volume. Now exercise is going to do the same thing. It's going to shift us up to the left because when we exercise, we activate the sympathetic nervous system and we decrease the parasympathetic nervous system. The release of catecholamines binds beta-adrenergic receptors in the heart, causing an increase in intracellular calcium within those myocytes. This also leads to opening of more of those funny channels where we get more of the funny current in the cells of the SA node. This results in an increase in contractility and heart rate. Remember, both stroke volume and cardiac output are going to be increased in this situation. Now, beta blockers actually directly antagonize the situation because they block those beta receptors on the myocytes. So they create a situation that is the exact opposite of sympathetic nervous system stimulation. Similarly, calcium channels such as verapamil or diltiazem directly antagonize the L-type calcium channels, so there is no increase in calcium influx. Both beta blockers and calcium channel blockers will shift us down the curve for this reason. Alright guys, quick flash quiz upon us. The blank circumflex / right coronary artery / left anterior descending is the most common artery to be occluded in the evolution of myocardial infarction. The answer is the left anterior descending. I remember the answer because the left anterior descending is the artery that must cover the most myocardium. Therefore, it's the most often involved.